Hello class, let's begin your peripheral joint manipulation 1 lecture. This is part 1 of a 2-part lecture series. These are lectures that are foundational for the course that you are definitely going to want to refer back to multiple times throughout the term and even throughout your future studies here at USA. So when we talk about motions, we're going to break them up into major categories. The first major category is going to be classical motions, and we'll often refer to those as physiological motions or movements, means the same thing. And then the other category is accessory motions or accessory movements, or you could argue non-physiological, but we usually don't use that terminology. Now, the classical motions can be both active or passive, and within the accessory motions, we're going to call these component motions or joint plays. Okay, so this is a slide directly out of your E1 manual to show you some examples of these different motions and some of the terminology. So you definitely need to familiarize yourself with these. I will say that this right here and this confuses people. Okay, so the only example given for a joint play is a distraction. That doesn't mean that all distractions are joint play. It just means that most distractions are joint plays. Same thing down here for component motions. We have glide as the only example we see here. So students will think, well, then that means every glide is a component motion, and that's not true. For example, the unicondylar glides of the phalanges at the PFE and DIP, those are considered joint plays, even though they're still a glide. So these are generally true, but they're not a rule all the time, which is another reason why we say don't make rules in ortho. All right, so what we're really dealing with here, if I could simplify it for you, is these osteokinematic motions. These are the things you did and measured in skills class. So these are like your flexion, your abduction, your adduction, your extension. So it's what you can actually see. It's functional movement, right? It's functional motion between the bones. Whereas accessory, which, and this is what we often use, arthrokinematic terms, means stuff that happens really between just the surfaces of the joints. Okay, so arthro meaning joint, kinematic meaning motion. So we have joint motion right here. So how are the bones moving versus specifically just the joints? Okay, and within this joint motion, we have joints that occur only due to an outside force, which means we can't volitionally perform these. And then we have things that occur under our volitional force. So we can just actively attempt to do these things and cause them to happen. I'll give you an example. If you look at your index finger right now, and I tell you to flex your index finger down, flex it down, you'll see that in reference to the anatomical position, your proximal phalanx is, when you flex, is being brought closer to your palm. All right? So we know that a glide is occurring because that's under voluntary control. And it's actually an anterior glide. An anterior glide because it's going towards your palm, and in anatomical position, the palms are facing forward. So an anterior glide is occurring. So every time I tell you to flex your finger, you're causing an anterior glide to occur. Now, a distraction would be when we take that MCP joint and we pull those joint surfaces apart. So if I say, all right, look at your index finger, and I go ahead and just actively pull those joint surfaces apart, cause them to separate, cause them to come apart and decompress. You can't really do it. You can't do that at all. Now, the only way to cause it would be to take your other hand, grasp your proximal phalanx, and pull to cause distraction of your MCP. Well, that other hand was an outside force. It was an outside force, which means that distraction in this case was not under our voluntary control, therefore it's a joint play. All right, moving forward into more accessory motions. All right, so why do we have these things that occur at the joint? Well, the joint surfaces move on one another according to these classical or physiological motions. So it's what occurs that we can't see with our eyes, but we can learn to feel it with our hands. So it's really essential for normal range and for painless function. And these are our two examples again of these accessory or arthrokinematic motions. So don't forget these interchangeable terms. Accessory motion is really the step, and sometimes you'll have to think of it as a test, passive range motion accessory. And what are we actually looking at? We're looking at arthrokinematic motions with that step. All right. So now we're talking specifically about that sub section of joint plays. So these are things not under our volitional control. They only occur due to an outside force. And why do we need them? Well, joints need this extra bit of give to be able to take outside forces in our normal daily functioning. Think about the times you stumble and catch yourself, right? So the outside forces of gravity and your body weight being thrown forward, your joints have to absorb that, but we don't hurt ourselves every time we stumble or trip or misstep, right? So we need the ability of our joints to absorb outside forces readily. So we need that extra give, that extra absorption capability. All right, clinical uses of traction versus distraction. So this is just to make sure you're sure about terminology, all right, and the difference between the two. They're often used incorrectly in the clinic in an interchangeable fashion, but they really mean two different things. Traction is simply the force. These are two opposite forces. So think about pulling things apart, grabbing both sides of something, pulling it apart. That is a traction force. So simply adding the force. Now, when we get enough force to get the joint surfaces to begin to separate, now we've actually caused a distraction. So distraction is simply a phenomenon or a result of a tractional force. All right, now we're talking about the other type of arthrokinematic motion, and that's a component motion. So these are things that are under our volitional control. Go back to that example of flexing your finger. When you flex your finger at the MCP joint, you're causing an anterior glide, moving from straight or an extended position towards flexion, anterior or volar glide. Okay, you're causing that to occur. And in fact, that has to occur or else your finger would not move forward. All right, so the beauty is what that's really saying use-wise is we can sync and link these together. I can link a specific type of component motion, right, into a specific osteokinematic motion. So I can go, all right, their shoulder, or excuse me, I can say they're not able to make a fist because their finger isn't able to flex. I need to make sure I check their anterior glide because I know that that correlates or is necessary to cause finger flexion at the MCP joint. We already went over an example. Okay, now this part is a little bit redundant, so just stay with me a moment. All right, so manipulation, mobilization. Okay, here's the dictionary's version of it, which you can memorize. And here is different authors out there that really got into a significant amount of detail differentiating mobilization and manipulation. So to try to make them very different, they had these high-level definitions. But what we really found is that this skilled passive motion to a joint that Paris and Patla initially coined makes them synonymous. And that's really important. So what's happened is that the most recent guide actually incorporated this synonymous terminology and said that that because they mean such a various amount of different things that you can use them interchangeably, you'll just have to more specifically say at which way you're using them, right? Like what speed or amplitude are you doing? Are you doing a small amplitude, high velocity therapeutic motion, which is also termed a thrust motion? So mobilization and manipulation, I want you to think of as synonymous terms in this coursework. Purpose of manipulation. So why do we do it? Why do we need to look at manipulation? Right? Why do we need to put our hands on patients and move their joints? Well, it's really important to check how much accessory motion they have. It's really important that we work to restore normal motion. This is huge. This is one of the things we do as musculoskeletal experts is we restore normal motion. We want to improve function. I can't express that enough. If they're a patient, you need to think functionally. And if they're a client, somebody who comes in without an ailment, they may just want a performance increase. So that's another purpose. And decrease pain. And these here are the biggest ones, right? Increasing motion, improving function, decreasing pain. And the two biggest, two most important, function and pain. Those are the two big ones. And that's what you should document. All right. These things are good too. When you think about it, well, what about somebody who was comatose? Let's say somebody who is in a medically induced coma based on surgery, and they're going to need to be in this comatose state for several days. Well, do you really want their joints to become stagnant? We move so much every day. This person is basically paralyzed due to drugs because maybe they would move a surgical repair site. So sometimes physical therapists will come in there and do passive range of motion to these people to improve nutrition and repair to the joints to keep things lubricated, to keep that synovial fluid metabolizing within the joint, and to help disperse spots in which synovial fluid has not spread across that articular hyaline cartilage. Okay, so when we think about manipulation, we used to think of that as separate terms, but you could easily write manipulation or mobilization up here interchangeably. So the title could be either. We really break them into two categories: non-thrust, which are not high velocity, small amplitude, and those are typically our distractions and glides that we're going to learn in this course. And then we have a whole series of thrust, which we're going to work on later in E1, S1, and a mandatory thrust course you're going to take here before you graduate. Okay, so what are the effects? So what's the benefit? What effect do you have on your patient? Well, there's always a psychological effect. There may or may, excuse me, let me go back. There may or may not be a mechanical effect, and there may or may not be a neurophysiological effect. Psychological effect, this happens every time. Remember, you may be the first healthcare practitioner to do such a thorough examination on a patient. We take a hands-on approach. We lay our hands on the patient, and therapeutic touch should not be underestimated. When you're moving joints, there may be a cavitation type of pop that occurs. So we always get a psychological effect. Anytime you're putting your hands on a patient's psychological effect, but we don't always get a mechanical effect. So mechanical effect means we're trying to make a permanent change to the tissue. So why would we want to make a permanent change? Maybe we're trying to stretch out adhesions, which are scar tissue, restrictions, just a shortening in that tissue. So we may want to be stretching that out. We may want to snap or break. It doesn't have to be snap. We may just want to cause it to neck and stretch. All right, and the neurophysiological effects. So Are we trying to fire those mechanoreceptors? And all mechanoreceptors are specialized nerve endings. So we have them within our joint capsule. We have actually a high percentage of them compared to other places in our body. And we have the highest percentage up in our subcranial cervical spine. So do we want to fire those? And if so, why would we want to fire those? Why would we want to fire these nerve endings? Well, they really hate with that pain gating effect. Now, in addition, we're putting our hands on their skin. We're stretching or slackening their skin. We're stretching or slackening muscles. Now, we try to, especially when you first learn, do these things in more of a loose pack position so you get less of this and less of that and more of this. But nonetheless, we can't isolate things perfectly, so we get all three. Okay, simulating the neurological system can help decrease pain, nociceptive pain, and result in muscle states such as muscle guarding. So, all right, those are the effects we get. So why do we do it? Well, if we want mechanical effects, for sure they need to have restricted accessory motion. That's for sure. If there's mechanical effects that you're trying to induce, you're trying to cause a permanent change in that tissue, then they should definitely have restricted motion. You may just want to gate their pain. You may want to decrease their nociception, decrease some of their pain centralizing behaviors. So that's your neurophys effects. And disease, if present, is not a factor. All right. So it depends on the actual state of the disease. I'll explain more in the future slide. So possible contraindications. So this is where we're going to pick up with this sort of disease things. There are no absolute. And a contraindication means you don't do it. It's contraindicated. So nothing's absolute. But there are a lot of precautions, disease states. Here's a great example. What about somebody who has rheumatoid arthritis and their rheumatoid arthritis is currently flared up? So they have an active systemic inflammation in the synovial lining of their joints. You're not going to want to do probably any end range manipulations at this point. You're not going to get mechanical effects. That would be contraindicated because it's acutely flared up. But we still wouldn't list disease states as a whole under a contraindication because you could do very, very, very low level, short duration type of mobilizations to just move that fluid to prevent it from becoming stagnant, to prevent that sustained distension of those joint capsules. All right, hemarthrosis is blood in the joints. If the joints move a lot, they're hypermobile, that's precaution. If there's surrounding muscle states that are holding or guarding over that, that's something we want to be cautious of and maybe want to change that first and then go back, but sometimes we can work through it. Here's inflammation, which I tied into the disease states. That's a precaution. Joint replacements are definitely a precaution. They're not contraindicated, but for example, you need to know what type of prosthetic implant that patient has because you may be doing a mobilization, let's say, for example, to a total knee replacement, where that total knee replacement fits in lock and key, and there is no gliding posteriorly. So why would you sit there and do posterior glides on it, right? Now, that's not contraindicated. It's just a precaution. You need to know what's there, and maybe you can go in the anterior direction instead. And then, of course, medically related drugs may cause you to be cautious during certain times of this. All right, so these are the variables we look at. These are the things you can change to get your attendant effects, to get more mechanical effects, to get more neurophysiological effects, to get more psychological effects. You can change the force. You can change how long you do it or the duration. You can change what type. Do you do an oscillation, small back and forth motion? Do you do a thrust? You can change the temperature. You can try to add heat. You can try to take away heat. You can choose how far you go, which is amplitude. You go to the end range of motions. You go halfway. Do you just go at the very beginning? Do you spend all your time at the very end? And then velocity is how fast. So these are all things we control, and this is why there's no cookbook answer to this. You have to take it on a case-by-case basis. All right. Thank you very much.